And welcome back to another episode of 15 with Finn, brought to you by Anika, where innovation meets insight. I'm your host, Adam Finn, here to guide you through the latest in regenerative medicine. In just 15 minutes, we'll explore the groundbreaking Integrity Implant System, its cutting-edge benefits, and the stories that inspire the use of this product for rotator cuff repairs. Whether you're a healthcare professional, potential patient, a curious mind, or someone passionate about medical innovation, this is your go-to podcast for staying ahead of the curve. Let's get started. Today's episode of 15 with Finn, where we cover all things about the Anika Integrity Implant System. I'm your host, Adam Finn, and our guest today is Dr. Christopher Baker from the Florida Orthopedic Institute. He is a board-certified Steadman Hawkins Fellowship-trained orthopedic surgeon who specializes in sports medicine and shoulder reconstruction. He is a lead investigator in multiple research studies, is published in peer-reviewed journals, and enjoys innovation and collaboration with industry. Good afternoon, Dr. Baker, and thank you for the time to speak with me today.
Thank you for having me, Adam. Appreciate the invite.
So I thought we could just start off with you sharing a little bit about your background and what led you to focus on the shoulder.
So background-wise, not in medicine, just kind of coming from a family of athletes and activities, got into medicine through that actually. Ended up in Pittsburgh for my general orthopedic training and felt somewhat deficient in shoulder training coming out of there. And had an inkling for it and thought that it might be something that I thought was interesting. This is back in the early to mid 2000s where, reverse shoulder arthroplasty was coming out and arthroscopic cuff repairs were becoming popular. So I decided to work with the guys in Greenville, South Carolina with Dr. Richard Hawkins. And they're kind of one of the early innovators and really involved in new cutting technologies, but also very thoughtful in the regards to how we manage patients. And choosing both operative and non-operative options, and started working with shoulder in that regard, and really kind of became a slave to the idea of perfecting rotator cuffs and total shoulders and reverses. I just think there's a lot of growth in the shoulder world that we can improve upon that has already been done in hip and knee. So that's kind of what drew me to shoulder surgery in general.
And how long have you been in practice now?
Going on 15 years now. I'm no longer the young guy in the group. I wouldn't say I'm the old guy, but I'm becoming the guy that's picking up more responsibilities and more of the difficult cases. So it's certainly become a transition in the practice of medicine as an attending.
And in those 15 years of practice and trying to chase perfection in rotator cuff, how have you seen that space evolve from a technological standpoint?
Yeah, so the rotator cuff has kind of still been that elusive thing, and that's kind of what drives me to get better is that, we went from just trying to get good repairs, good releases, good exposure, and good fixation. And I think over the past 15, maybe even 20 years, I think we've really, I don't want to say ever perfected it, but through working with industry, creating stronger implants, smaller implants, more reliable techniques, we can fix just about everything. And so we have plenty of repair ability. Unfortunately, we don't have a whole lot of heal ability. And so what got me into working into advancing rotator cuff repair is trying to improve what we already thought was good. We're good at fixing it. If we don't open the box and we don't look at the rotator cuff again, the patients tend to be pretty happy. But if we look behind the curtain and see, the result of our labor, it is quite surprising how often failure occurs after we repair rotator cuffs.
So you've been augmenting rotator cuffs for a number of years now. Can you discuss the need for augmentation and how your patient selection fits in there?
Yeah, so I'll even go a little bit further back and tell you how I realized all my patients weren't doing great. I have some very big name physicians that I work with here in Tampa. You can name them, and that gets me into studies and trials where I'm trying to help them enroll patients. And we had one study where we were looking at a new anchor, and that anchor's protocol on the study was to get an MRI at 3 months. And then again at 6 months. And the MRIs were coming back at 3 months, which nobody really does. Nobody really gets MRIs on rotator cuffs at 3 months. And my rotator cuffs were coming back torn pretty frequently, actually. And luckily, in this case, the 6-month MRI maybe showed that we shouldn't be getting MRIs at 3 months because things don't look normal. But even at that 6-month point, when we started getting MRIs, I was noticing tears that I did not anticipate re-tearing, I should say, failing. And so I was seeing tears that are relatively basic, 2x2 kind of 3x3 centimeter, 2x2 centimeter repairs that are just failing. And so I started in that vein trying to improve upon that. And this is probably, 2010 to 2012, something like that. And the first thing was the dermal graft, and that was really what we had at the time. This is past, xenograft stuff that had kind of failed in the past. And so I would take a dermal graft after my repair, and I would repair a dermal graft on top of that through shuttles and suture techniques and that kind of stuff. So it was doable, and we could do it, but it was certainly a labor to do, and certainly at the end of a long case or a long day, wasn't the thing I looked forward to at the end of my case. So after working with my dermal grafts, which were doing fine, other implants started coming out, other biologic implants that had faster, easier implantation techniques. And so we started to use those in addition to dermal grafts. And I found that maybe in partial tears, I was having some improvement in my repair healing rates and patient improvements. But in my large tears or full thickness tears, I still was seeing a relatively high failure rate. I don't want to do anything in my practice that may have a 60% or 70% success rate. I want to get, into the 90s. That's where everything that we do in orthopedics. So that's where I really started to explore other options in grafting techniques.
So that brings us to Integrity. Obviously, you're one of the designing surgeons for the Integrity system. I'm curious how you were first attracted to Anika and how this implant is different from what you were using previously.
Yeah, so the integrity evolution for me actually was almost entirely happenstance. I live in Tampa, which is near where the Parkes company is. I had been using some Arthrosurface implants, and when Anika acquired Arthrosurface as well as the implant company, I had already been working with their implants, and so we got to working more. And then I found out this implant called HIAF. And so HIAF is this hyaluronic acid based scaffold that can be used in cartilage restoration. It's available in the EU and not quite yet in the United States, but hopefully will be coming soon. And I started to understand what Anika really is. And Anika is really a gel company. Anika is Orthovisc and Monovisc. And I found out that the engineering of this HA, for lack of a better word, can be made into a solid, and really can be made into any solid. It's almost like creating a plastic or printing something, really. And so I became intrigued by this and started talking to the guys about the HIAF implant, and then we started spitballing the idea of grafts and how it might play in the rotator cuff repair world. And so for about, I guess how long has it been that we've been working on this? Maybe 5 years total. So for about a year or two, we kind of played with different mixes. Me and Dr. Codd, I'm sure you've had Dr. Codd on this podcast, worked with the engineers and the team, including you, obviously, on the right design, the right shape, the right contents, and we were able to weave a little polyethylene into that HA, and now it really started to take shape. It was something that could have a little bit of strength, be manipulated in the articular space, and started to really shed some light on what we could really do with it.
So Anika has recently released two new sizes in addition to the rotator cuff sizes. We now have a 25 by 60, 40 by 60. What are some applications that come to your mind immediately for usage of these larger implants?
Certainly, the larger implants lend themselves well to open indications. Arthroscopic would be, depending on the procedure that you're doing, somewhat more difficult just because of the size of the device, but certainly larger tears that gives you now opportunity for. But open repairs and I guess I should say augmentations, Achilles, quad tendons, triceps, patellar tendons, all of those other larger structural tendons that we may want to augment.
And you're unique in that you've actually had a couple of patient success stories that have been shot with video and interviews with those patients. Can you give us a little background on those couple of patients and how they're doing today?
Yeah, so we have some patients that have really been, I would say, cheerleaders of what we've done for them, in that it's changed their life to the point that they're able to get back to the things they want to do that they had to basically forego. One is a gentleman who's a big outdoorsman, hunter, ATV kind of guy, and he stopped being able to lift and do the things that he wanted to do in those environments. And we did his repair. He had a full thickness, massive repair, augmented with the Integrity implant. MRI showed just a phenomenal healing of the tissues. And the guy was just strong as an ox at 6 months. I mean, he was just ready to go. And he has been a real proponent for us. Interestingly, as wild as he is, he got back to life and actually had an ATV accident to the point that he broke his scapular body on the operative shoulder. And he comes into me to see me, and I say, "Oh my gosh, you did this thing to your shoulder blade," and it healed up, and luckily his cuff held through it, and he's right back to doing all the things he wants to do. The other patient is a hairdresser. She had been unable to really do her job. She had to cut her patient short, and was found to have a high-grade musculotendinous partial thickness tear. She had been treated by one of my partners, who's a great surgeon, but doesn't really do much graft augmentation stuff, and knew that I dabbled in this. And it was in a position where he didn't feel he could repair it adequately. And so he referred her to me, which doesn't happen much in our world. We have really good surgeons in our group that don't need help. And so he referred her to me, and we did just a simple onlay repair. We did no sutures, no anchors, just placed the graft right on top of her partial tear. And again, followed her closely, got the MRI. The MRI showed a great healing of that myotendinous injury. And again, she returned back. I mean, within 3 months, she's back to work, full duty, full client loads, and just super happy that she's gotten back to life and be able to take care of her family.
I think it's always great to always remember the patients and the lives that we're able to change, not only through your hands, but through technological advances in medicine. So I appreciate you sharing those stories. I'd like to spend the second half of our discussion around clinical data. Obviously, that's one crux that a lot of new products face, in that there are no clinical data at launch. So you recently published a paper called MRI and Patient-Reported Outcomes of a Hyaluronic Acid-Based Rotator Cuff Augmentation Implant. What was the goal of the study, and what were your thoughts around setting this up?
Sure. I think your first comment is exactly the issue, right? So when you come out with a new implant, a new device, a new technique, there's no data. All right. And that's what everybody wants, is data. And so what I really credit Annika to kind of hearing me when I said I thought this was important, and funding MRI studies basically to look at what we were doing. So from day one, we started following patients. From day one, we started getting MRIs. From day one, we started looking at outcomes. And the purpose of doing it so early wasn't to prove anything. We can't prove anything with small numbers, but what it does do is it gives surgeons some feedback as to what we're seeing as the early surgeons using the implant. And interestingly, we found things that we had no idea we would find, right? So the first thing we found is I wanted to show, remember I talked about that 3-month MRI study that I was in. I get a lot of comments about grafts in general causing stiffness. I get a lot of comments in general about rice bodies or foreign body reactions. And I think a lot of those comments are not really based on evidence or facts. I think they're reactionary. And so I think a lot of people and surgeons blame pain or stiffness on a new implant or technique, when in fact it might just be our patient selection, right? So I wanted to show our patients, and this is the bad part of the study, is that I cherry picked the patients. I picked my best patients with no pain and full function, just like the two that I discussed with you earlier. And I wanted to show what normal MRIs looked on my best patients at 3 months and 6 months. And as a surgeon who's doing new things, when you have that back to look at those images and say, oh, this was what Baker's images looked like at 3 months, and these patients were doing great, but you have a patient that's having a hard time, you can rest comfortably that those images are normal if they look like what we've published. And so what we found, again, unexpectedly, was that the graft actually kind of really increased in size, both in thickness as well as diameter, both in the X and Y axis. And so that graft that I did for that myotendinous injury, that on the hair cutter that I said, my graft, when I placed it, just barely reached the zone of her injury. It was very medial to the level of the AC joint. And when we got our MRI, what we saw at 3 months was that graft was thickened and growing towards that injury area. And by 6 months, not only had the thickening kind of worked its way back into the tendon and incorporated, but that medialization of the graft over top of the injured tissue had healed in and kind of crept millimeters beyond where we had put it. And so that's what we see a lot of times in these patients is almost like an aggressive healing response in the subacromial space. So what I didn't want was for folks to interpret that as a negative thing. I think that's a healing response. And I want to see that. I want to see biology. I want to see healing. I want to see incorporation. And most importantly, I wanted to see it resolve over time. And that's what we're seeing. So we see this kind of early growth, healing environment. And then we see this remodeling that incorporates over time and becomes less distinguishable from the native tendon below it. So that was the goal of the study itself.
So I want to touch quickly on thickness because I think it aligns well with what our animal studies showed. Looking at your pre-op, your average thickness was about 4.5 millimeters for the cuff. And then both at 3 and 6 months, you see almost an additional 3 millimeters of cuff thickness, which is interesting because the graft itself is only 0.75 millimeters thick. So what would you say to a surgeon who's wondering about this thickness? Where does it come from? What's happening?
Sure. So it's exactly right. It's exactly what we see. If you have a partial thickness tear that's measuring about 4 millimeters in thickness, and you place this graft on top of your injured tendon, the concept is that the incorporation of the tissue. So you have this lattice of polyethylene that is woven with the hyaluronic acid, the HYAF material. The healing body, the body's healing response, basically macrophage will come in and chew up that hyaluronic acid, and behind that, those fibroblasts will come and lay down the new tendon-like tissue. And like other implants in this market, the concept is that if we thicken the tendon, we're offloading the injured tendon below. And then you can start to see even healing response of the injured tendon itself. And that's the concept of the articular sided injuries, because that's always that little bit of a leap of faith. Okay, how does putting a graft on the bursal side heal? Okay, that makes sense. But how does the articular side heal? If you look closely in the data in the literature, partial thickness tears can heal on their own even. Okay, so if we could stimulate that by getting this hyaluronic acid healing environment, we can really kind of increase that thickening of the tendon, offloading that injured tendon below, maybe even allowing that articular sided tendon to heal. So that's the concept, is thickening the tendon, adding a new layer of that tissue through the healing of the macrophage and then fibroblastic invasion. And most importantly, the hyaluronic acid is gone. By the time you get back in there after 6 months, there's really no HA left in that thing. You still have polyethylene. So you end up with almost like a little sandwich of tendon-like tissue, a layer of polyethylene, and then your healed rotator cuff below that.
And with this study, you've got a lot of accompanying images, and you've had a chance to speak on the podium and showcase these images to other surgeons. I'm curious what the feedback, if any, has been from those surgeons after seeing your 3-month and your 6-month MRIs with the Integrity implant.
I think so far it's been eye-opening and certainly piqued interest. Again, there are other implants out there that don't seem to create much reaction or biology. And I think there are a lot of surgeons, using dermal grafts, for instance, consider that to just be dead tissue on top of your tendon. It never becomes tendon. It never changes. Your body will still grow into it some. You will see some native host cells that will grow into the graft itself, but it still remains skin, if you go in and remove it. But this is going to be something that should be, other than the polyethylene, more or less indistinguishable from the body. So I think that's number one, is that we're seeing something. But the two is the biology, some type of increase in the healing response. So that's what I think most surgeons are really interested in.
And lastly, on this study, I want to hit home the difference between 3 and 6 months, because it's a common question that we get from both surgeons in the field is, for whatever reason, should they do a look back at 3 months and they see that the site is looking angry or inflamed, what should they do?
So certainly, in my opinion, unless you believe there truly to be an infection, which is highly unlikely in rotator cuff repairs, I probably do a couple hundred a year over 15 years. I mean, we're talking about 3,000 plus repairs that I've done. I've had one infection and a rotator cuff repair. Okay. And that was a very poor host early in my career that I probably never should have operated on because he was old in a nursing home and probably picking and whatnot. So probably the worst possible patient to pick to operate on because he didn't do well with conservative management. I tried it and it didn't work out. 1 in 3,000. Okay. So if you think that your patient has an infection, it's a rarity. If you don't think there's an infection and you think that patient's having pain or stiffness out of the ordinary in the 3-month phase, pause and relax. Let your patient know that there's a little inflammation going on. That's probably good for the healing process. I see a lot of overreaction to all graft implants, not just the integrity implant, that the patient has more stiffness or they're concerned that there's some stiffness. That's okay. Stiffness is good. Stiffness is probably the body's healing response in a good form. That stiffness will loosen up. When I was young in my career and I saw stiffness, I got very worked up. I would do cortisone shots. I would consider whether I should take them back and do a lysis of adhesions. I haven't given a cortisone shot or re-operated on a stiff shoulder in years. Now, idiopathic, frozen shoulder, I do that occasionally, but not post-surgical stiffness. I think that's going to happen in some subset of patients, especially the smaller tears or the partial tears. So the MRI doesn't really change my mind. If I see a really exuberant healing, I want to see that. I'm hoping that as you see those patients as a surgeon, you can look at our images. And we've also posted these cases on ViewMedi as well. We also have posted some of the same patients in arthroscopic techniques in arthroscopy. So there's multiple resources that your doctors can go to or surgeons can go to look at these cases before they jump the gun and start doing things to the patient that may not be necessary.
All right, good to know. Pause, wait, things should settle by 6 months. Perfect. So pivoting to the other study that you're involved in, you are part of a large multi-center study for integrity. Can you give me a little bit of the details of that study and talk about your role as a lead PI?
Yeah, so currently really all we have are case reports, right? So it's early on, it's hard to collect data and set up a true study. So we have several case reports out there from multiple surgeons that are just their patient experience. Even my study that we just got accepted to JOEI, that is really just my experience, right? It's not a high level study. So what we wanted to do was create a more standardized study, multi-centered. I think we have 8 or 9 enrolled surgeons, maybe 10 now enrolled surgeons. We're going to get over 150 patients, and they're going to be followed prospectively in a normal manner. They're going to get SANE scores, quality of life scores, the constant score. So we're going to get, standardized, normal study, multi-center prospective evaluations of these patients, not just by me, not just anecdotal stories from one doctor at a time.
And you were pretty early in enrolling for this study, and looking at the results, you've got, I believe, 3 patients now that have hit their 1-year mark. Can you speak at all to how those patients have done at the 1-year point?
The study-wise, yeah, we're just over a year into the study, so the patients are doing great. We're not seeing any regression in their findings. Patients who, not even just the 1 years are obviously doing well, and there's not a lot to say there. Even patients that end up having partial recurrences or something like that, they're acting as if most patients would who have partial recurrences. Again, if you do enough rotator cuff tears and you're dealing with a 3x3 tear, you're not going to see 100% healing full footprint. You're going to get some Sagaya 2s and 3s that, don't look so great, but can remodel over time. That's really what we're seeing is the expected healing response without a lot of recurrence at this point in time. It's too early to say how much we're going to have, but certainly we're not seeing any degradation in their function over time.
And last question for you, I'll try to give you a softball. Looking at the data, you're pretty close to the 100 mark for total patients augmented with integrity. Just curious what your tips and pearls are for surgeons that are newer to the system.
So if you're new to grafting in general, I'll start there. If you're new to grafting in general, I would encourage you to do some partial repairs. So have a patient who has let's say a 50% partial bursal-sided injury. Start with that patient. It's an easy case to do. It's easy to monitor their MRIs, and you can see kind of what results you're going to get. Now, again, partial tears in all surgery are more likely to get stiff. So I like to move them with their hands at their side. So I do internal external rotation more or less right away. I do pendulums and table slides right away. I don't make them stay in their sling, but I don't let them do overhead for 6 weeks. So in those partial tears, keep them moving low so they don't get stiff. and then get an MRI at 6 months and see what it looks like, or even 3 months. You might see that little hypertrophic kind of healing that we see, and then that will get you comfortable with the process. Okay. Once you feel that that is actually improving your patient's imaging and their outcomes, then start to apply it to your full thickness injuries, or vice versa. It doesn't matter. But the partial tears are just a very good way to feel comfortable with it and then monitor it. As far as the technique is concerned, I'm a big fan of soft cannulas. We have a lot of doctors that like hard cannulas and don't use the soft cannulas. Talking about like the passports, or what's the other one called? The Gateway. Yeah, those are the two of the main names that I know. The reason is that it allows you to pull your deltoid fascia away from the surgical site. And there's a little skid that comes in the implant device tray, and it basically opens up the soft fenestrations in that soft cannula. And then basically, as you implant your implant, you remove that skid and you pull back on your soft cannula, and it just allows the implant to deploy a little bit easier. It's friction. You're just trying to drag this large graft through the cannula. Sometimes the hard cannulas don't give you quite as much vision and exposure. So if you're having any issues with a hard cannula, try soft cannula with that.
Good to know. Well, that concludes our time for today, Dr. Baker. I greatly appreciate your insight and am very happy to partner with you as we further rotator cuff repair.
Thank you for having me.